So good morning every day, everybody. You see, my brain is starting. Good morning, everybody. I can really tell that it's Friday today. Finally, after a few weeks, is something that remind me that I need a break, that I want to be just playing with my daughter, and I don't want to have uh, the routine. This crazy, but it's beautiful. Thank you everybody to be here. I bet you guys are tired to see us. We exhausted but happy because we really believe in the power of education. We really believe that that's gonna be the only way that we can change the world. And the idea to put this together and connect dentists all over the world is beautiful to me to connect my people from Latin America, my Colombian dentists, and all South American speaking people, and also all the other parts in the world that I have in the opportunity to be traveling and creating friends all over. So thank you for all of you guys that they here. And today we have an amazing friend. I have the opportunity to meet him in Dijon, France. He was recommended by Francesca to him to get and take my courses since we're talking about biofunctional occlusion, physiological occlusion. So then I have the opportunity to meet Miliau Le Berre. Finally, I think I made the pronunciation kind of correct
Yeah, you did.
after pronounced it 1,000 times. It took me an entire course to just to learn to say that was no Emilio, that was Milio. And even that if we spend multiple time together, I have to practice with him half an hour before to be able to pronounce the name correctly. So he's a great friend. Thank you so much to being here. So let me pass it to Hamid.
Good morning. Good morning, everyone. Good morning, Milio. It's great to finally meet you virtually, anyway. But I've heard so much about you and so much about your train of thought and your modality. I've, of course, always heard about Dr. Legal, but frankly, I'm the first one to tell you, honestly, I have no idea what he stood for. So I'm really looking forward to what you have to say and teach us today. Thank you.
Hello, everybody. It's a pleasure to be there. Pleasure to see again Javier. As he said, we met in Dijon. It was a few months ago in December. We didn't met before. I was attracted of his way of thinking occlusion for the jaw position with tensing and having an idea from your functional position. In my mind, I was seeing what he was doing, and I fall in occlusion by the way of mastication, and I saw at the same time what I can do with this process on mine. It's a good way to improve our skills and to be able to do more
Okay,
things.
so let me connect you with the rest of the people. Let's see what we're gonna talk today. So today, Emilio had the beautiful opportunity to be trained by people that always been thinking in chewing cycles, but he went to a really deep level of understanding. And what's fascinated to me when I start talking to him that we have similar approaches, that we always thinking that the occlusion is a cofactor into in all the problems, systematic problems. So he was telling me stories about how patients with pain in another part of the body or dysfunction, after just after just they make the adjustments of the occlusion into the chewing cycles, how those pathologies went away, and how after the patient has dentistry done, another dentist replaced crowns, and the patient come back to the same symptomatology. So we will get to that story because it's really impressive to me. But also, part of what I want to connect in this topic is that even that he has this strong foundation in chewing cycles and trying to develop remove all the nociceptive input during mastication, he found a niche to connect mandibular position as one of the elements to start the process. And the beauty is that he also thinking that, but he has different mechanisms mechanisms to take the bites. And it's a full holistic approach with different influences of different people, but at the same time, we get similar to the same factors. So today we're going to develop what is going to be the principle more in depth about the Dr. Legal into the chewing cycles, because that's going to be his lecture.
I will present it on Friday, on the 1st May.
Yeah, so in the 1st May, he's going to have more graphics and videos. That is really amazing. It's difficult to talk sometimes about mastication. Yeah.
It will be easier to understand because it's a word.
Yeah. When we talk and you will make this, it's different to see what they really seen in those slopes, because the dentistry that they do is focused. That is the hardest part to me, because it's hard to see into the mouth when the really chewing is happening into that surface without instrumentation. But they develop protocols in the way to observe the face of the patient by itself during chewing cycles. And I think we can benefit tremendously in whatever philosophy or whatever thinking process, we learn this consideration to the chewing cycle. So first, tell us a little bit about how you get involved into this physiological thinking.
In fact, when I came up to dentistry study, I had my first professor was Jean-François Lauré, with the body study of Marcel Le Gall. And his guy was giving us the class of anatomy on occlusion. And first thing he taught to us was to bring us some notion of anatomy. And I can remind, it's funny because the first course we attend, he came in classroom with a tennis racket. He came in the class, he take his tennis racket and he mimic the gesture of service tennis, just to explain us the pathway of the first lower mandibular molar on the enamel bridge of the first molar, the first upper molar. So we didn't understand anything by this time. We were deeply in this world of mastication, but we weren't aware of what was the subject. And 3 years after, I moved in another university, and here I discovered canine guidance, group function, and I said, "What the hell? I didn't understand what they were saying," and it was in my 4th year of study, so the other students have facility with canine guidance. What I didn't understood the logical approach. So that's where my first question came, to see what's happening in this world of occlusion. In this time, I was lucky because there was a new professor in this university who was with Alain Horner. And Alain Horner is a guy who teach me some skills from knactology, and he was a friend of Jean-François. So we were two in the university to speak the same language about mastication. So we became friends, and I enter this world by this way. And few years later, I passed my exam. Unfortunately, Jean-François Lauré died 6 months after I passed my exam. I practice by myself the technique of mastication. And 10 years later, I've already met Marcel, but not quite closely. He went to Reunion Island, where I lived. And it was a great opportunity, and we met, and we became friends. So I came back to him. And what is very interesting is because I have practiced by myself in my corner the mastication, and Marcel evaluates with another guy, which is Roger Jurger. and he brought me some little things, little details, but making the difference to improve my knowledge on mastication.
Okay, so what is the concept of mastication? What is the main thing that this approach pay attention?
Okay, you know, the story began in 1980, 1780, when Marcel and his buddy Jean-François were sit in a class and they were watching a video from a spironactograph. You know, the device that permits mandibula to do the same moves as you can see on patient in the same time. They have the approach
It's like
towards,
a robot, an
yeah,
articulator
it's
that
like a robot.
simultaneously.
Yeah, that's it. They were watching someone who were showing some food and what the robot was doing. And at the same time, they was looking at and they were saying at themselves, but it doesn't do what we do clinically. Where when we examine occlusion, we ask people to go in a way in out. She is showing in the other side, and that's where it began, because they say, okay, maybe our philosophy of our dentistry philosophy of watching people from a movement, a motion starting in MIP going outside, which is centrifuge, is not the good way to examine patient. So that's where the story started.
So what you say is most people, we believe that the chewing cycle starts for maximal intercuspation,
No,
and then
but yeah,
and
but
then the circle go for the, normally when we create artificial, we may from that maximal intercuspation to go out in this direction and come in. And
yeah.
then your studies shows that the physiology of the chewing cycle, we start to a cycle that goes out and then comes in first.
What Marcel and Jean-François described is that you have two phases in mastication cycle. You have a dental phase and you have a non-dental phase, which is a preparatory phase. So we don't have to think, I think that we don't have to think the mastication cycle beginning in MIP or finishing in MIP. We have to see the movement in a global way and thinking about dental phase and non-dental phase. So
Yeah, it just makes sense because I think when you have the spoon like me that they just bring me breakfast, you teeth are apart. You're not starting for maximal intercuspation. Then you will put the food in your mouth, and I think the mouth prepares somehow to be able to do the. It's not that we are starting with the teeth like that, because in what moment we will throw the food in there, right?
Yeah.
So it's more like that preparatory phase maybe can be that preparation that you will say, I'm going to put my food here and I'm going to throw it to this side.
Even when you open your mouth to smash the food.
Okay.
Because
some sort of sensory, some sort of proprioceptive.
Yeah.
I think that even has to be with where I don't remember who was talking about. Oh, John was talking about how the baby looks for the nipple. I think we have the same sense when we have the spoon, right? We kind of try to look for that spoon, and we will know how we're gonna make the chewing cycle. Okay, so what else you guys look at it?
Well, I have a procedure to examine my patient, which is based on my coworker, because 1 year ago I have an endodontist who came in my office to work with us. He didn't have any knowledge of occlusion, so he started to ask me questions, and I say, okay, I have to make a procedure to be clear, to be able to find the same things and to be repeatable in a sort of view. So what I explained to him is I have to identify first the fuse blown. It's a way to identify where is the problem. Is it TMG problem? Is it a neck problem? Is it a cracked tooth problem? Is it an endo problem? Is it a perio problem? Is it? It can be so much of thing. Because when he first came to me and asked question, he asked question for healing problems on the rondo, because on the rondo he had such great procedure. I don't know how he does, but he's very great, Cedric. He called me after. I say, okay, I have my procedure of rondo. I'm sure 100% it's okay. It's clean. It have to heal, but it doesn't. So he asked me, and I just examine and say, okay, if it doesn't heal, it's maybe because your healing process is a fuse which is blown. And in this case, what I remark is I have a occlusal trauma on this teeth, on this tooth. So I said to him, you can wait what you want with the trauma you have on the teeth, on the tooth. You cannot afford good healing. So my first thing is to find where is a fuse and to identify it. Second thing I look at is behavior of the patient, because if I go for my procedure, and if the patient have the best way I can improve his occlusion, but is still going to traumatize his occlusion, I think you can do some good thing for him, but it won't heal in 100% of chance. So I ask people to see their behavior, to watch their behavior, to be aware of what they do with their jaw in the day. Often what I can observe is when you have a problem of whatever problem is on your fuse, is when the fuse have blown. Often when you ask people, you say, okay, this was in this time of the year. So when you ask more about what happened to the patient in this time of the year, it's not a psychological approach, but it explains a lot of things, I think. They said, oh, there was a mess in my life by this time. I don't say it's stress brings the problems, the occlusal problems, the healing problems, the fuse problem. But what I say to patient, I say, okay, maybe by this time you have started to bite more, to clench more, and to be able the fuse to blow by this time. So my approach is not to. It's just to explain what people can do by themselves. It's a good thing to your work, because when people come back and say, oh, if the fuse is a crown fallen, they say, oh, I may have clenched too much by this time. They don't say you don't have done a bad work on.
So you educate the patient to make them part of the problem.
Yeah.
Explain them that can be conditions that can technically overload the bites, that eventually what you call the fuse that it blows. It's talking about that weakest part of the system that is the one that you.
I often compare it to a sportive for running women or men, and say if you have a good knee and you have a good physiotherapist, good shoes, good EPO or good drugs or whatever you want, if you are still running 10 hours a day, your knee will crack. It's impossible to. So that's the way I explain people to be aware of what they do with their jaw, to try to relax and not to overload the occlusion.
Now, during this process, can you tell us a little bit about, and I know that, but this is going to be part of the questions, but I think we want to build in to know like what you're thinking first. So the patient come to you, you're trying to find that fuse, but
I show the patient the connection between his behavior and overload occlusion. Then I go for to a questionnaire to just to have an idea of what are the other fuse that can have be blown, but the patient is not aware of. Here is a more holistic approach. I look for itchy scalp when people are itchy, because it's the trigeminal nerve who is the same nerve for the scalp.
yeah.
I go on to palp the internal angle of the eye. Often when people have a point, painful point here, it's 80–90% occlusal problem or clenching. I look for earache, for pain in the neck. I also look for tachycardia and effortless pulmonary breathlessness.
What was that?
When people are just suffocating because they can breathe.
Insufficient breathing patterns.
Yeah. Why? Because the trigeminal, how do you say that?
Connection.
The nucleus of the nerve. Yeah, the gray nucleus of the trigeminal is very next to the vagus, vagus nucleus. So often, but I go very prudently with this kind of signs, because you have to be sure that it's not a cardiac problem too. So it's when you have tachycardia, which is not explained by classic medicine. So it's what I look for is yes, you have.
I mean, it's a fact that when you compress the vertebral artery by the neck, you deplete the brain, and then it's articles that it shows that the pressure change when you freedom the vertebral artery.
Correct. Yeah, I was going to ask.
That's a point, but there is another point, which is when you clench a lot, you activate the nerve, the trigeminal nerve, and you have two ways in the nerve. You have a proprioception way, which is going from the outside to the inside, to the nucleus. You can easily imagine, because we have a feedback way on each nerve, which can explain that if your nucleus of trigeminal is very impacted by this clenching and always been activating, you can have a repercussion on the vagus nerve. So that's the point.
I have an amazing article that eventually I'll share with you guys about that anastomosis, all going for the connection between the trigeminal, the ganglions, it happens in the cortex,
with the glial cells. It connects. And I go to look for women. We have endometriosis symptom likes, and we have also irritable bowel syndrome. So on something I find very often is a sensation, a feeling of nail in the heel.
Nail
When
and
I
what?
have
I'm sorry? What was
What
that?
a feeling of having a nail planted
Yeah.
in the heel. With when I have a lot of that signs, I say, okay, I go for more deeper in my in the way of thinking. It's a occlusion problem. So what I can propose to this patient is before I have already done the job for behavior, giving advices. But when I have such list of problem, I go to compete with anesthesia of the pterygo-palatina fossa in the lower compartment, just to try to relax, to calm the input that the trigeminal nerve give to the nucleus. So, and it brings a lot of amelioration for people who have very, very big problems. And here is the point where I go to occlusion.
Okay. How do you relate the masticatory chewing cycle with the mandibular position and mandible trajectories?
Okay, first I go to check and to verify the mandibular position. I don't care about mastication in the first step. To be able to check the position, I go for the first thing I learned is manipulation. I know it's well known to be operator dependent, but what I see, what I can observe is when my coworker come to my office to work with me, they don't know to manipulate in the way I do, which is one way. But they have an approach with many way to do, which interfere to the relaxation of the muscle, because I think it's the key. They stress the patient. They give some movements that don't permit the patient to be relaxed. So after a training moment, what I can do, tell is, even my wife, which is a fantastic mastering in bonding, she finds the same position as my endodontics find, but he didn't find in the first time. He had to train. But now, if we see the same patient, we find the same position. The thing is, we find the same position on easy patient to manipulate, easy to relax. I've tried, because I attend the course of Francesca. So I use her technique of cotton walk on cotton roll. I try it, and what I find is I find the same position doing with roll cotton on cotton walk. I find the same position than I find when I manipulate, and I find the same position than you do with your tens, but on easy case. On difficult case, that's where I think manipulation is not enough. I need to tense to relax people, but tensing, it's easy to do, but it's not easy to record the bite with after you have tense.
What would, I'm sorry, Miliau, what do you consider a difficult case? Are you talking about a lot of joint adhesions? What constitutes a difficult?
Yeah, it's a question I have often. it's something that you have to feel in your hand. It's when you have the good manipulation, you feel you don't have to lift the jaw. It's only you have to help. It's very
it's easier to.
It's very easy. It's you see the patient get relaxed very in a few times. It's very in 2 seconds you can have the
Correct.
you can have the relaxation. But even when you relax, that's the problem of the manipulation. I think is you have to deprogram engrams in the brain. Sure. The only way you have to do manipulating is to put your finger in on the upper teeth to be able, not the teeth to get engaged together. So the problem is when you put your finger on the lips, you can perturb your patient on that's
perception, correct.
Yeah, that's the problem. So I have a device, a tool that I have used for many years too. Is what let's see, it's an interesting story. It's what developed Jean-François and Marcel. It's a doctor which name is Le Berre. He was he went from the philosophy of the jig of Lucia. What they remarked it is when you use this device, the jaw gets retracted. Yes, it goes backward. Right. So they try to make it more flat. As Lucas said yesterday, it's the same principle of the quiz. I think it's all interior stop. What they did in a second time, that was with Marcel and Roger Jorger, which is a buddy in France, and they go furthermore in the concept just to, because they were persuaded that the thing is the functional position is related to the way you swallow on the position of the tongue. So okay. They try to make a place on the anterior stop to permit the tongue to be just behind the incisor. So it's a way that I think it's better than cois to be able to have an idea of the position of the tongue, on the influence of the tongue on the jaw position. But the problem is you have a problem of phonation. You can't test phonation.
Phonetics,
some device, it's but it's quite interesting because in the approach, what they are doing is to make in PMMA an anterior stop which is entering the upper incisor, and you have a plate just behind like this, and you have a place which is we permit the tongue to go
above it.
Above. And what he says is you have to grind the anterior stop to permit the mandibula to come in the good position. Often you go too much forward and the patient bites on the slope where he shouldn't not, and the mandibula get retrude after.
Correct.
So he grind. Is the point is to find a position where you find an equilibrium. So it's a concept of wheelbarrow, to carry in your garden. So if your wheelbarrow is well loaded, it will be in equilibrium. If you have not well
one
loaded,
side or
it will, that's the point. So at the end of the test, you can find one point, which is always repeatable. So that's the way they go.
Okay.
Now,
It's an anterior deprogrammer of some kind and creating engramming for a position.
yeah, yeah.
But wouldn't that have error? Correct me if I'm wrong, but something like that, you can engram anybody to any position almost. Correct?
Yeah, we can. That's the point that I want to do, and then we get in time issues, so we need to
Yeah.
find a connection. Before we start with the question, let me make a
Okay.
point,
Go
because
for it.
I think this interview is really unique, just for one reason. Milio was taking my courses in France, and I used him for level 2 patient as a level 2 patient case. We level 2, we manufacture an orthotic, we take
Hello,
a physiologic,
Sebastian.
and then we get a neuromuscular bite, a biofunctional bite, but by using all the postural principles and everything. And I don't know if you mind that I talk about your case, Milio. Is that fine? Okay.
Yeah.
So Milio, for instance, has premolar extractions into the uppers. And then if you see him when he's talking, he has a huge space into the posterior teeth. And when he's speaking, the anterior teeth are here, and you can see a tremendous gap into the back. This was been one of the more difficult cases to equilibrate, because I have two pressures. The first one is I found a position for him, and he became pretty much behind edge to edge. So imagine the gap was in the back. So then in level 2 also we teach how we make the coronoplasty and the equilibration of the spleens. But imagine the pressure to do it on him, that he really know and understand masticatory chewing cycle. So he was transmitting to us everything that he feels. What I'm building into this point, because to me, I really believe in mastication, but I think, and also Miliu says, it has to be combined with mandible position, because he can remove all the proprioceptive input into the bite as he had it, but he has a skeletal discrepancy. So that's why you see so much of this discrepancy in the back. So his bite is really unsupported. As a fact, when we made the orthotic was like 3 millimeters high into the back, but in the front, almost none. Because technically the mandible did this movement, and that was put the
It was a decompressive movement, not so much forward movement. It was a decompression.
It was just decompression. Then remember that we made a full analysis, so we compared the X-ray, and then we noticed that the morphology of the joint also has a lot to do, because it's not the same that the compression in a shadow flat eminence, that patient can go eventually more anterior, and that's why you see the class 3 patient, mostly they have many things in common. One is the pitching, the posture of the body. The other one that we see is a kyphotic pattern neck. And then we normally see flat eminence. And you see these patients, mostly they don't have that much TMJ problem. And different than class 2, that they really stiff, and that's how he is. So when we relax the muscles on him, the only chance that had that joint was decompress and keeping that slow. And in the way that we take the bites in a neuromuscular way, but we make the packing of the joint, because we induce swallowing patterns during the process of we taking the bite. So now I get Emilio with an orthotic, and Emilio make all the courses. So I have the chance to see him in level 2 and 3 or 4 months after in level 3. And I get to see what he was. He was committed to use it. So he is like in this thinking process of developing a research to combine the two connections. So I want that, Milio, you explain what can be the difference to treat the chewing cycles in an habitual position, and what can be the difference to adjust chewing cycles in a reposition mandible position by any philosophy, I mean, that you change it, because you know what was the toughest part to equilibrate him is that he came to a cost-to-cost relationship into the sides. So then we're trying to remove interferences. Something that he noticed is that when I did the orthotic, I already build up the occlusal planes, 15 degrees in excursive movement, so I just know what's
what
left.
I think is when you just think about mandibular position, jaw position, you are in a static view of the condyle on the way that you close and open. And what brings showing cycle is to be able to stabilize the same condyle, but in 4D, in 3 dimension, but in the motion too. That's the point. To make an example, if you think you have a good position, good stabilization with posterior teeth, which is very, very well fitted in MIP. And when you think about chewing, when your mandibula goes on the side to catch the food and to crush the food, you have a phase where your teeth are together. If you're in the way that almost of us have learned, we ask people to grind the cusp, not to have any interference in this movement. But if you think in 4D, the process of the motion of the jaw, you can just imagine that if the cusp are not working, who is working for her? It's the jaw, the condyle. So it will overload the condyle. If you restore the slopes on the cusp, the buccal cusp, to permit the jaw to be guided to the MIP, the load will be shared between the cusp you have restored on the condyle. That's my.
But you don't think that the condyle, when you have like what will define in your own case, what it will define it like people will call it long centric, because when you go to maximum anticipation, you go behind, but you technically function in here. So when I put the orthotic on you, your initial position was where your AP was, and then you develop chewing cycles to that position.
Yeah.
Let's say that now you don't have the orthotic in place. So let's say that you're gonna chew. If you start with food that is big, maybe your joint will decompress automatically because it's a fact that you want to function more anterior.
But you know what? I'm not able to chew. I swallow.
So do you think that if you're
it's my problem. My wife is always saying, take time to eat because you. But I know I don't use my teeth as
you suppose.
Yeah.
So then we get to the.
On the orthotic, I can.
You can.
But
because you have enough support.
Yeah, I have much support, but I have to improve the shape of the orthotic because to be able to chew, just considering concepts of mastication with cycling slopes on.
Yeah, but I think the structural pattern is really, really crucial in this situation, because I think your structural patterns are so far away. You're in a perfect class 1 biting behind, but you want to function here. So everything that you have is interferences. That's why you cannot recruit the food. So I think this is when we start connecting the points, and we will say, okay, how we will benefit for an orthodontic treatment that can be faster if I speed it up with corticotomies to try to move the teeth with a better relationship. So, so you consider. Okay.
I'm sorry. Let's move on. Finish that point.
Just the point that we want to do is it's important that the people, and they're going to be able to see in his lecture, is seeing that mandible position is still being important to be able to have proper mastication. It's not isolation. It's not that the patient has a bite like his, and the more equilibration he has.
It can be isolated.
Okay. So the two components. That was just the point that I want to do with this. Okay. Hamid, go ahead.
Perfect. All right. So, Amelia, we're going to start with our section, the fun section of the interview. All the questions everybody's been so
I
eager.
think Francesca is excited here. Chewing, vertical chewing socks. That's good. And also,
No.
Francesca was a patient. That's beautiful because I have these two people that I couldn't believe. It was honored to be able to work in their mouths and see what it is. And definitely, I think we have, the more dysfunction we have, we get more into this. That's why we have orthotics here, Hamid is on orthodontics, and we were playing with ourselves to try to find out how we can make this better.
A dentist dream to work on another dentist, right?
Yeah.
Oh my God. Okay.
All right, Emilio, first question. Tell me what is occlusion to you, and who were your influence? I know Dr. Legal is one of the ones, but you mentioned
definitely mastication.
Mastication. So to you, it's all about function.
Yeah, I will say that muscle decontraction is a point. I associate to brain deprogrammation. I think it's very important to make disappearance and to refine the physiologic movement of closure on of open and closure. And point two is to obtain simultaneous closure contact when under swallowing pressure. When you swallow, to be able to have the simultaneous contact. That's the second point.
Simultaneous bilateral contact?
Yeah.
Is that what you're talking about?
Yeah, when you swallow. Last point is to obtain mastication guidance to stabilize the condyle in a motion way of.
Okay, so just to make that, so by guidance, you really you don't think that all class 1, class 2, or class 3.
It's not a question of class 1, class 2.
Interference. You don't think of them as interference.
No,
you
not
think
at all.
of some as actually guides.
When I met Francesca first time, she explained very well that you have a vertical chewer and horizontal chewer. But I said, she said she was right that horizontal chewer don't like to be trapped in vertical ways. They don't. When you are horizontal, you don't like to be trapped in a vertical vertical way of doing your cycle. But what I said to her is, when you have a vertical chewer, you can transform very easily them in a horizontal chewer, making the diagram of showing wider and to work very easily.
Hamid, let me just explain that part. We believe in interference class 1, class 2, and 3, but we mostly see for an static point, and then we try to prevent to have those when we create an actual pattern. When I was making the adjustment in him, they try, like sometimes they leave some class 2s in the movement because
that's what I understood from his speech.
Yeah, so when they have this, they don't want class 1 in this side, but they want this slope to work together with the opposite side in some way. I mean, he will explain that. Honestly, this is so complex. I talked to him and Francesca a lot, but this really, really need training. Honestly, we are able to see in trajectories, that's what we do, but this, imagine that the problem is it's hard to see inside, you know?
But it's a process. You have already to first you have to be able to read a map on the teeth, to be able to say, okay, that's a cycle entry that mark, and this one is another one, and this one is missing, on this one. You have to be able to read, and after, when you know how to read, you know where you have to put your plot of composite to improve the mastication. But
understood.
That's a point very funny, because when thinking about, you told me just in the beginning of the interview that when we have crown. The first case I had was with crown, and the crown was patient was having a click in her jaw. So I remove the crown and I adjust a professional one, which very beautiful cycle in slopes. And patient didn't have any more click. I put back the old crown and click again, and I do the removal. I remove each time same results. So it has an impact on the trajectory of the condyle. Definitely.
Thank you. All right, question number 2. You spoke in very detailed about your occlusal pattern and in mastication. What other factors are you considering? Are you looking at the posture? A lot of our speakers talked about posture and sleep, airway.
Now I attend the course of Javier. I look at. I was aware there was link, but I didn't have any knowledge on it. So now I am more eye sharper to see what happened.
Fantastic. How about airway?
Airway, I don't look at, but I have seen the work of Javier. It's obvious there is a link. If you think about the tongue, on what the tongue can tract on the larynx and all this area.
Talking about the tongue, are you examining patients for a tongue tie? And do you perform any pharinoplasty?
I ask people in my initial examination to swallow and to watch where the tongue is.
Okay. All right. Let's talk about the diagnostic records that you take. What type of diagnostic records do you take? And the second part is that what equipment do you use?
It will be the same question. I use a tool that if you don't have, you can have it because it's my eyes. But the good news is that everyone have eyes, so it's based on observation. If you are a good observator, it's easy to.
Correct. You could have eyes, but if you're not observant.
Yeah, exactly.
Yeah, but you can learn. You can learn. Second tool is my iPhone. I take a lot of video capture, motion capture to think about how people are showing their cycle, their cycle, and to have a picture of how is the map of mastication before and after. I have questionnaire I complete to be able to have an initial status of how the patient feel. I pay a lot of attention to the change that the patient can feel during the treatment.
Fantastic. So you're not working with any kind of X-rays or CBCT or?
I do, but when I have doubt or where the condyle can be on a huge problem, but it's an easy case. I work a lot with simple device.
I got you. Miliau, do you work with other professionals? Do you believe in an interdisciplinary approach?
What is very interesting is the feedback of my physiotherapist. I'm thinking in Eric. I work a lot with him, and when he says, when I fix a good position, a good jaw position, he says it's incredible how fascinating is the manipulation of the neck. He says I know when you are in the good position. Yeah, when on people where you have trouble to get a good position, is able to say no, you don't catch it yet. The second thing which is interesting is he was very reticent with my anesthesia of the pterygoid fossa compartment. And when he said, I said him, okay, let's try once. And he said, wow, it's incredible because I have a laxity to be able to manipulate the mandible and to do exercise I didn't get before. So now he asking me on tricky case to anesthesia just before he sees the patient.
So were you making the injection into the compartment?
Just behind the
second molar.
last molar.
Okay.
Behind
Going,
the upper,
yeah,
behind the greater palatine.
Yeah.
Yeah,
Okay.
and going in the direction of the ear,
The lobe.
lower part of the ear, not to have injury in the nerve, because it's if you go too up, you can damage the nerve, so you have to be careful. And the last collaboration I have is with my beautiful wife and my endodontist, because they bring me back to omni practice, and I can see they can see now the difficulties they have in omnipratic, and I don't see I'm part of their process. I'm not the, it's when you progress in occlusion, finally you are in the center of the treatment oftenly. I'm not only in this position for them. I am part of the healing process of endodontic problem. I'm part of cracked tooth problem to identify why these tools have cracked, and to find the fuse, and to go forward in the occlusion analysis.
Fantastic. All right. So can you walk us through your sequence of treatment, and how are you now that you're incorporating some of the new things about the occlusion? Can you walk us through your sequence of treatment with one patient? Let's say that you see, like your own case, where you see there is a vertical discrepancy.
Yeah, always the same. I go to identify the fuse. That's the first point. I go to
So diagnosis first, of course.
Yeah, correct the behavior, because I know if I don't correct it, I will have trouble, because it won't help me. I go to find a good position for the jaw, so that's where I can use manipulation, and if it's easy, I don't go furthermore. If I have doubt, that's where I can go for anterior stop of deglutition. I can go for tensing. I can go for, if I have doubt after this point, I go for a splint to be able to be sure that's a good point of the good position. And this is where my physiotherapist can help me to say me, okay, you are in good position or you are not. And after I go to restore mastication in this new position.
On top of your split?
On top of my splint, or if I am sure if it's an easy K, I can go directly on the teeth. Because I go with composite. What is magic with composites, that if you are wrong, you can remove it, and you can do it again. You can increase. You can do with ceramics. So that's a good.
Perfect. Perfect. Let me ask you something. Where in your analysis does facial considerations come in? Do you take that at all into consideration? You know,
depends on the case, because it depends of the fuse which have blown. Because if it's TMJ, I won't go for aesthetic first. I will go for position first to find a position, and after that I will think about aesthetics. But I will think about aesthetics before doing my final restoration, sure. If people comes for the tooth which very grinded, often it can be aesthetic approach, the first approach. You know, I think when you have a patient coming for aesthetic approach, they don't care about joints. So you have to take care about where you can bring your aesthetics, if the patient is okay with that. And in the second time, you say, okay, I can do it for you using mockup, DSD, and what you want. But in the second time, the explanation go to TMG process, because say, okay, I can do it, but if I do it in this way, I have to give a new position for my jaw. So we have to go to check the jaw position. So all have their place in the treatment process, but not at the same place. But at the end, it will be the same, because it's I think it's in the approach, in when you discuss with the patient, that you change your approach. But finally, it's always the same. You have to have a good aesthetic restoration point you want to achieve, and making your jaw good position jaw to
work properly,
to be able to reach these aesthetic outcomes.
Fantastic. Do you have any questions, Javier?
No, I was reading the question for the audience, and then you finish with this, and then
Okay.
I will go over.
All right. So the next question, I'm not sure how much. You're not doing any surgeries, are you doing, Miliau?
Yeah, I do implantology on perio too.
Are you currently using any of the biologic factors like IPRF or PRF or PRGF? Are you familiar with the growth factors?
I do for implantology, I do PRF of the poor.
PRF of the what?
Of the poor, not the rich, the poor, because because in the blood, in the blood, you have all the elements, and PRF is just a way to separate. So the less can do the more. So I just take the blood and use it like PRF. But
I see. I see. You don't separate either.
What is interesting in your question is what are the other factors that can help us to
help with the regenerative?
Yeah. What I noticed is when people have, it's implantology who gave me this point of view, is when you have trouble with your bone, when you have trouble with your gum, often you find some vitamin C deficiency or vitamin D deficiency, because we don't eat as we should. And if people have carency of vitamin, how the hell the joint can heal? I think we have to think about how people eat and the quality of the food they
eat. So in your mind, nutrition first, but but I'm hearing, I'm assuming that you don't have any objection in addition of something like that if you knew that it's going to increase angiogenesis and bring more blood supply and more healing factors.
I'm open-minded, so no.
Fantastic. All right, let's go to the last three questions. Question number 9 is you know, I think somewhat partially you answered. Are you noticing any postural changes after your treatment? Are they expected, unexpected, positive, or negative?
Not only postural changes. When I move, when I change very big big jaw position, what I notice is very severe difference in the posture. That's quite clear. I'm just thinking about a man who was coming to my office by ambulance. He was bent in half in the office
Wow.
to walk to my chair. And when I gave him a new position next week, the week after, he went straight, and now he's coming to the office by himself on motorcycle. So great chance. What I noticed,
Adventures.
what I notice on mastication point, it's not so spectacular, but I'm thinking about a friend of mine. She was 14 when by this time, and she had any trouble of how do you say that? Your ankle, which is not broken,
Yeah,
but
the anchor is twisted.
Twisted ankle?
Yeah.
Yeah, twisted ankle. And it came so lot, come again. I analyze her mastication map. I add some composite to restore it because unfortunately, she had an orthodontic treatment. The problem with orthodontic treatment is that you often when you open the palatal and with device such as quadrix, you don't know?
Quadrix? Yeah.
It's
Quadri health is called. The one
Okay,
that has
rapid maxillary expansion.
Yeah. And oftenly you turn the six, so
Correct.
the guidance, the cycle guidance is not in front of what it should be. And I restored it, and the ankle twist disappeared. 10 years later, because she's a friend of mine, she was with her father on the phone, and she said, I felt something hard in my mouth on the phone. And 1 month later, she was complaining with her father to have again some twist ankle. And I redid the entrance, the cycle entrance of mastication, and disappear again.
So let me guess, you had some sort of cones with composite, and one of those snow cones came out.
Yeah, I think it gives more stability on the jaw, so maybe connected to our sense, the eyes, the internal ear. It can give some stability to the body to know where it is in the space and not to fall down. So this is something I ask people for their relationship to sport. If they always do sport, and often people say, "Oh no, I don't do because of what?" And sometimes they say, "Oh, because I'm always falling. I'm not very
coordinated,
stable.
I'm not stable." And this puts me a light in my mind.
Very well.
On last thing is very important. It's not postural, but I have a case 3 months ago when I reestablished jaw position. It surprised me, but the man said that he can hear more than he can before. So I can see on tachycardia, on pulmonary breathlessness, I can see change, but I don't have the tool to say for sure it's occlusion, but seeing it quite a lot and oftenly, you say there might be
There's a
some
correlation.
yeah.
Yeah. Fantastic. So, as with you and many of our other invited guests, we have seen that the spectrum of this view of occlusion is very wide, and
Yeah.
so we're asking everybody, well, how do you see the future of occlusal education in universities? Do you see it as something that's going to change and come out of this very mechanical model? Or
I think we have to think about the educational process, because you can get to this this point of view in a few moments. I think you have to consider the bite, the jaw position. That's the first thing that we can do in university. In universities, you can have a good approach of mastication, but after, I think we have to give an holistic approach to give the curiosity to go forward. But it's very difficult. We can't. I think all of us, we didn't get into our knowledge in
overnight? Yes.
yeah. Francesca has a good way of thinking it about speaking about you are in phase 1, phase 2, phase 3, phase 4 dentistry, and I think it's a good way of thinking process, and it's a way that you can say, okay, for phase 1 you have to be able to examine this patient in this way. When you are easy with this way, you can go to phase 3, and after phase 3, I think in university we have to give the opportunity to the student and to the teacher to be aware of what there is behind only the mechanical point. That's the point. And after, to be able to give the people the guests to want more and to improve their knowledge.
Absolutely. Now, I know you didn't mention a lot. I know you spoke about repositioning the jaw or the condyle, or in certain cases. Thinking about the processes in the joint itself, in terms of the movement, do you ever think about dissect the movement in your mind? What is the actual movement happening? Is it a rotational movement? Is it a translation? And what is the ideal position? Do you ever think about what is the correct position for that condyle?
Or what is the position that you found more consistent when you finish the cases, right?
Right.
I find I look at the picture of the motion of Javier, so I can say no, it's a combination, that's sure. But the point is, I think when people are very retreated, you can find some rotation too. But rotation is maybe not the point that we should watch. I think what we could watch, we have to watch, is a position where the joint can permit the patient to cycle very easily. It's very easy to know, because if you are not in the good position, your patient will say, I don't feel comfortable. It will be the first thing that he will say to you. The second thing is when you get the good position of the jaw, your fuse don't blow anymore. So I think it's a good sign of stability, and stability is not very easy, to find, because we work on patient. who are alive. So the all is progressing, the old nest is coming, and you have to do with it. And I think the position is evaluating too. So it's not a. I don't know if we will get a definitive answer to this question.
Well, I appreciate you taking a shot at it. Very well. All right, Javier, why don't we go ahead to the question from people?
Yeah, no, first, so then in reference to the occlusal pattern, I think that's what he's going to choose in the lecture, because the other question is always the contacts that we need to really see that to understand.
I won't concentrate on jaw position because you have so many beautiful lectures to make it. I will concentrate on mastication pattern, on how it works.
Yeah, beautiful. I'm lucky that I have homework his lecture that he gave me to use for future education. It's amazing the material that he has. So we have one question here from Lydia Javish for Brazil. It's a pleasure to see her. She's an orthodontist for Brazil. As a fact, she also teaching courses in Dijon, France. Okay, so she say, do you train the patient with the orthotic to really chew? Because all the system was programmed with a big pathological freeway space. Can you measure that? Chewing gum is not going to work with the orthotic because it sticks. Maybe it works on natural teeth. By the way, I'm gonna answer part of that, Lydia. It's a chewing gum for dentures people. Hamid, do you remember the name?
Frieden.
So that is
the gum.
Yeah, it's a gum.
Yeah, there is a gum. It's called
I use Hollywood Max.
It doesn't stick to acrylic?
No. What is very smart with this gum that is very easy to hydrate, very easy to crash in a few seconds, not too hard to
make it soft,
to chew. It's very good. A good tool because when you have to comment dire effacer
excursive movement,
wash, to clear the piece at the end of the appointment, you give it and it clear all in a few seconds.
Oh, that's good. But the rest of the question, so the rest of the question was, do you train the patient with the orthotic to really chew because all the system was programmed with the big pathological freeway?
I was using only splint like Michigans at this time, and now I'm trying to apply to get together your conception of orthotics and to
anatomical orthotics.
Yeah.
Okay, perfect.
Beautiful.
Oh my God, that's been awesome. Okay.
We have come to another end of another beautiful interview. Thank you so much, Emilio, for
it was a pleasure to share
your valuable experience. Javier,
that is also to feel. It's beautiful, that feeling. I don't know if the audience is having the same excitement that we having, because Hamid and I, we just talk after here between the meetings. We're talking and we learned this. We need to study this. And chewing cycle is something that is really important. I'm so sad because we were having a course with Francesca. I was going to Geneva to have this course in June. So I was so excited. She has the courses in multiple pieces and she make a group to make an intensive course. And I was waiting just like crazy to have it. And now it's going to be until next year. But I'm really thirsty of knowledge, man. I really think it's too many different ways to do it. It's so valuable to find the common points,
But be careful, Javier, because when you enter in the world of mastication, there's no way back.
It's a big rabbit hole, right?
Yeah.
Oh my God, I'm willing to do it, honestly. It's nothing that I love more than education. I mean, I think my journey, my life, I never stopped one day. That's why I have the opportunity to meet all you guys. putting effort, just traveling and knowing that you need to learn it for different perspectives. It's fascinating the information that is out there, and I'm glad that Hamid and I we were able to put this information together to try to bring people close to what we read every day. So thank you
Yeah,
so
no,
much,
that's
Emilio.
a great point, Javi, because truly, Milio, and I don't say this just to say it, but truly one of the best part, aside from the fact we're occlusion geeks and thirsty for this stuff, is meeting people that are like-minded and they're just as passionate as we are. And so it's been a true pleasure. Thank you so much for spending your time with us.
Thank you so much.
Okay, thank you guys. So I will see you guys at 1 p.m. At 1 p.m. we're gonna have Dr. Dara,
Sure.
and Dara is gonna talk about integrative whole person. She's an orthodontics, and she's gonna tell us how amazingly she integrates everything from lips, teeth, tongue to toes. That's
I
gonna
can't
be
wait for that one.
as a part of their lecture. I just remember all the speakers. Thank you so much. We're still missing a few of the titles of the lecture, and this weekend we have to do the schedule of the marathon. This marathon, for the one that I listening now, is going to be 12 hours of lectures. We're trying to ask some of the speakers to have it recorded so that eventually it will make the workflow easy and be able to control any technical problems that we have. So many of the speakers, they send the video. We asked them to be in the range of 30 minutes. I received some tiny bit longer, but we're going to try to adjust it. This is still is going to be record, but I think it's beautiful to feel the energy when people get connected. I think that's the fuel that Hamid and I we need, because this is exhausting, and that marathon is going to be a crazy marathon, not just for us, for our families as well.
Yeah.
So it's going to be fun. Again, we're going to leave that material for you guys. We're going to try to orchestrate the schedule in a way that it works for our international speakers. For instance, for Milio, is what time is there, Milio?
It's 6 p.m.
So 6 p.m. He is farther in France. He's in an island. So
I'm not. I'm
yeah,
in the middle of the Indian Ocean,
yeah.
between Mauritius and Madagascar.
Wow.
So he's 8 hours apart. So we need to try to start. So guys, be prepared. Part of the plans that we have is I think the marathon will start between 6 and 7 in the morning Miami time. I mean, we're trying to find middle points to be able to help to be engaged and feel the energy for the European part as well. And still, we don't have the schedule totally set up. We're thinking maybe we can feed ourselves for your opinions. What you guys how advise you to do? We were thinking eventually to have 3 blocks, because still we need to have for technical conditions, we need to log out and log in for the social media. So eventually to try to do something like that. And again, it's not definite the time. Honestly, Hamid and I, we really need to study what is going to be neutral time. So I don't make the people
Time
to
zones,
wake too early or going too late to bed. But definitely just this is like a hurricane. So get provisions, take it. Get your gas with car. Get food. Get water.
Toilet paper. Toilet paper. Don't forget.
Yes, and get ready, because this is gonna be so much fun. Thank you for the beautiful people that was watching you.